Good afternoon, colleagues, and welcome to our first grand rounds of 2022. We've got a really exciting lineup of presentations this afternoon, and I'm going to invite our first speaker of the afternoon, Dr. Goulet, to upload his slides. He's going to give us a presentation on behalf of the Division of Neurology on longitudinally extensive myelitis and lupus. Over to you, MV.
Sorry, I was just going to unmute myself and I'll share my presentation. Cool. All right, so can everyone see my presentation?
Do you mind going to presenter view?
Sure. How's it going now?
We're seeing at the presentation view instead of presenter view, sorry.
Okay. Let's try again. At this point, can you make it out?
No,
Okay.
The slides are very small, so they appear the way you would see them when you're presenting. But if you go to, it's a slightly different. Yeah.
How's it going now?
Perfect. That's perfect. Okay. Thank you.
All right. So my name's MV. And I'm going to be presenting on the behalf of the Department of Neurology of a rather interesting case of a rather unfortunate young lady where a few teams had input in, and I think she's had a relatively good outcome. So our case is a 17-year-old young lady. She's got a medical background of 2 prior episodes of TB in 2014 and 2018. And in 2017, at the age of 14, I believe she was diagnosed with SLE. At the time, she presented with typical symptoms of a malar rash and arthralgia. She had positive serological markers. And at that point, she was diagnosed with class 2 nephritis and an autoimmune hemolytic anemia. So between 2017 and 2019, she was treated with maintenance immunosuppression of prednisone and azathioprine and was going well. However, in 2019, she developed her first episode of optic neuritis. This presented as visual loss in her left eye with no perception of light. This is quite important. Retrospectively, she actually reports that she'd had a prior episode of unilateral visual loss in her right eye during February 2019, which was also consistent with an episode of optic neuritis. So on the basis of this recurrent optic neuritis, she had her immunosuppression escalated to monthly pulses of cyclophosphamide between November 2019 and March 2020 when the whole world fell apart. So in March, about 3 days after her last cyclophosphamide pulse, she developed myelopathic symptoms. Her initial symptoms were that of paresthesias and weakness in the lower limbs, and these progressed rapidly over a course of about 3 days to a completed paraplegia with a thoracic sensory level and loss of sphincter control. She didn't at this point report any vomiting, hiccups, or altered sensorium, which will play into the presentation a little bit later on. And to speak to her examination, when she first came into the neurology division, she had signs of her prior optic neuritis with an RAPD in the left eye, and she had reduced visual acuity in both eyes, basically counting fingers. Her fundoscopy showed bilateral disc pallor with no features of active papillitis, and she had no further cranial nerves or bulbar signs to show. Her motor examination, I think, showed that she had some mild weakness in the left hand, actually just clumsiness in the left hand and some shoulder abduction weakness. But in her lower limbs, she basically completed paraplegia, no power at all. She had some involuntary flexor spasms. And at the time, no reflexes were elicited in her lower limbs. And as I said, she had a T4 sensory level. We then went on to do some investigations for her. She had a full blood count in U and E, which were normal. Her neutrophil count was normal, given that she was on cyclophosphamide. She had a lymphocyte count of 0.81 and a CD19 count of 250, which maybe I can discuss later on in the presentation. The urine at the time was inactive. We did some serologies, and obviously her ANA and a double stranded were positive. A Rho was also positive. However, her C3 and C4 were normal. HIV, Hep B, C were normal, and her syphilis serology and B12 were normal. Her serum aquaporin 4 serology, however, later on came back positive with a titer of 10. She'd had a CSF, which showed a lymphocytic pleocytosis with the proteins quite high, 2.47, and a low glucose with an IgG index of 0.87. And for those that don't know, basically an IgG index is when we compare the IgG synthesis in the CSF compared to that in the plasma, and we make an index out of that, and greater than 0.65 is positive. She also had 8 polys, 37 lymphs, and no red cells, and cultures for TB were negative, as was the FTA. I just wanted to show some of her radiology, and I'll go through this a little bit more slowly, but basically these two, this is a T2 sagittal and transverse images of her spine, and what we can see first of all is that throughout the spine, throughout the length of the spine in this sagittal cut, there is high signal, which is confluent and extends from the craniocervical junction basically through to T10 and actually went down to the conus, if we could show the rest. And in the kind of transverse sections, we can see that it seems to occupy the entirety of the cord. And so this would be called a transverse myelopathy. And because we think it's inflammatory, it's a transverse myelitis. And the term longitudinal applies to the fact that the extent of the sagittal high signal extends more than 3 vertebral segments. And this is kind of a hallmark of what she does have. In addition to that, she had uncontrasted imaging, or uncontrasted and post-contrast imaging done. And we can see again that the cord is swollen and that there is contrast enhancement in a patchy fashion throughout the cord. And when we look at it in the transverse section, again, there's this kind of rim of contrast enhancement, which was actually visible throughout her MRI. And so she was diagnosed with seropositive neuromyelitis optica. And so what is NMOSD, or neuromyelitis optica spectrum disorder? So it's a severe inflammatory disorder of the CNS, which is classically described as optic neuritis with concurrent myelitis. It's existed for a very long time, and kind of descriptions go back to the 1800s, and Devick described the kind of seminal report of this in 1894. Initially, it was thought to be an endemic variant of multiple sclerosis, and so you may read in the textbooks or older textbooks and older literature of opticus, or Asiatic or Asian optical spinal multiple sclerosis. This term, however, has fallen away. The typical course of this disease is quite aggressive, with multiple relapses and accumulation of disability and eventually death. And we've had a few patients in our service who died from NMO. It's associated with a pathogenic anti-aquaporin 4 antibody, which targets astrocyte epitopes, which results in secondary glial dysfunction and demyelination. There's increasing, well, not increasing, it's widely recognized now that there is also, in addition to the aquaporin 4 antibody, and you get aquaporin 4 negative and anti-MOG positive NMOSD, which has resulted in a kind of expansion of the clinical description. The radiological hallmark of NMO is, as we've seen in my patient, this longitudinally extensive transverse myelitis. And with the description of the antibodies, there's been a greater recognition of other syndromes that present with positive aquaporin 4 and MOG antibodies. So the diagnostic criteria have gone through several iterations over the years. The current international trial on NMOSD criteria, or NMOSD diagnosis criteria, recognizes 6 core clinical syndromes. That's optic neuritis and myelitis, like seen in this patient, the area post-tumor syndrome, which basically involve, when there's involvement of the dorsal medulla, people develop intractable hiccups and vomiting, the acute brainstem syndrome, which would basically be brainstem signs in the setting of an inflammatory disorder, acute dicephalic syndrome, where patients develop narcolepsy and intractable insomnia, or an intractable somnolence, not insomnia, and then a symptomatic cerebral syndrome with typical lesions. The diagnosis for seropositive NMOSD is made with one core clinical syndrome and a positive antibody test. And the seronegative diagnosis requires two core clinical syndromes to happen, not necessarily at the same time, but can be concurrently, as has happened in this patient. So this is just going through the history of the descriptions of the diagnosis of NMO. I'm not actually going to focus on that, but if you'd like to go back to it later, you can. So the MRI findings are kind of core to the diagnosis of NMOSD. And the core kind of findings are those of cord findings and brain imaging findings. And each of these kind of will go with a clinical syndrome. The most distinct manifestation of NMO, although, is the longitudinally extensive transverse myelitis. This usually involves the cervical and upper thoracic segments of the cord and is, like in the pictures you've seen, characterized by T2 hyperintensity and hypointensity on T1 sequences. That's not really important to know. There's a preferential involvement of central gray matter where there's an abundance of aquaporin 4, and spinal cord atrophy may be seen later on in cases after the myelitis has transpired. So this is like a picture from a seminal paper on NMOSD, and as you can see, the pictures on the MRI look very similar to the ones that we've described in this case. Another hallmark of the NMOSD is the pattern of the optic nerve involvement. So when you hear inflammatory optic neuritis, probably what comes to mind is multiple sclerosis. Well, in the setting of NMOSD, they do develop optic neuritis. Often it's bilateral, often very severe to counting fingers or 20/200, and is often also described as long segment involving more than half of the optic nerve's course. I'm not going to speak too much about the hemispheric lesions in NMO, other than to say that there can be multiple. You can get these large, fluffy, cloud-like ones that's seen in the DA, with all these finger-like or spindle-like extensions in the white matter. You can also get finer, more lattice-like involvement of the white matter. These are all consistent with NMO, but by themselves wouldn't be able to be diagnostic without a positive serology. So the typical differential diagnosis for NMO, at least one that you'll come across in the medical literature, is it NMO or MS? And here is a list of things that are would help differentiate. Mainly its MRI findings, and so our friendly radiologists would be able to help with that, hopefully in the reporting. There are some red flags and mimics for NMO, and I think the most important thing to know is that longitudinally extensive transverse myelitis is not pathognomonic of NMOSD. Longitudinally extensive transverse myelitis often occurs in children with ADEM and in 17% of patients with MS. In addition, you can have a coalescence of short segments of transverse myelitis, which will then look like a long segment of transverse myelitis. I think more importantly in this setting, infections and metabolic diseases can look like transverse myelitis on the MRI, specifically neurosyphilis and TB, which are common, and vitamin B12 deficiency can give you a transverse appearance. In addition, if you have a large cord infarction, it could also look like transverse myelitis. With regards to the antibody tests, these obviously have their own sensitivities and specificities. In general, false positives are rare. However, the sensitivity of the cell-based assay, which is basically the gold standard, is about 75%, and the immunofluorescence and ELISA are 64%. I think it's important to know that you can't use an aquaporin 4 test indiscriminately, and so in the asymptomatic people, it's unclear what that test means or what it predicts. And so indiscriminate testing is not advised. With regards to the anti-MOG, which is the newer described antibody, and since the beginning of, I think, last year or the year before, it's been available to us at Skier. This test is positive in a variety of CNS demyelinating conditions, and so you really need to be led by your clinical picture and your pre-test probability of what the anti-MOG antibody means. I'm just put up some of the kind of typical red flags for NMO for people to come back and look at. So there's some clinical red flags that people should be concerned about, and some radiological red flags that one should be concerned about. I won't spend much more time talking about that though. With regards to disease association, so I presented a case of NMOSD in the setting of someone with FLC. There's a variety of autoimmune diseases, malignancies, and infections that NMOSD has been associated with. This is mainly done, mainly reported with case reports and small case control studies. And there's a very active Turkish group that publishes systematic reviews of these case control studies. Basically, with regards to kind of autoimmune disorders, the most strongly associated are Sjogren's syndrome and lupus, as in our case. But NMOSD has been described in some unlucky people with rheumatoid arthritis, sarcoid, APLS, systemic sclerosis, and ankylosing spondylitis, amongst others. And then also has been described in some organ-specific autoimmune disorders like autoimmune thyroid disease, celiac disease, autoimmune hepatitis, and interestingly, specifically neurological disorders like myasthenia gravis, and even with CIDP and AIDP. There's been debate about the association with TB for more than 30 years, where there was a master's thesis in a paper that came out of UCT asking, well, would patients with longitudinal extensive myelitis and TB, could this be a version of Devek's disease at that time? And basically, there's been several studies, and the jury's still out. Tigerberg published a case of 14 cases of NMO where 76% of their cases had positive TB, but Chinese published basically a case of 88 cases where they only found one case of concurrent TB with NMO. And so this raises some questions about geographic and potential genetic variability in the concurrence of TB and NMO. Just with regard to the prognosis for NMOSD, if you're aquaporin 4 antibody positive, this is a negative prognostic marker. It indicates a high risk for further relapses. In anti-MOG disease, this antibody at this point is thought to represent a monophasic illness. You can have monophasic seronegative NMOSD, and I think that's just important to note. However, we're very, very reluctant to let people who are seronegative go without treatment and treat them as monophasic. With regards to the radiology, upper cervical region.
If you could try and wrap up so that we can have some time for discussion as well, that would be great.
Sure, I'm pretty much done. But just to say that basically aquaporin 4 positive has a poorer prognosis, and that none of the brain lesions or cord lesions specifically provide any prognosis. Treatments are that of immune therapy. Acute relapses are treated with steroids and plasma exchange, and long-term prevention, which is a big part of the treatment, is historically done with oral steroids and steroid-sparing agents. However, we've been more frequently using rituximab in the past couple of years with some good results. Importantly, the treatments for multiple sclerosis should not really be used in the setting, as they can make things worse. I'll now open the floor to anyone who's got questions.
Oh no, that's the Zoom meeting that I'm supposed to be on that I'm.
So I'd like to invite Dr. Bateman, who is the consultant on the case, to make some comments. Okay.
Hi, thanks very much. And thanks, Envy, for such a useful review of an important condition. We wanted to bring this to your attention really because it's something we see quite commonly. It's I think Envy mentioned, in fact, as far as some of the CNS demyelinating disorders are concerned, in our context, we see more NMO spectrum disorders than MS. And that's been similar to countries in the East and in Asia. Here in South Africa, we see quite high rates of NMO spectrum disorders and much less MS. And it's an important condition because it's a distinct entity which is diagnosable and which has very important treatment implications which are time sensitive. So, as Envy said, unlike MS where relapses may accumulate silently or with fairly small amounts of disability per relapse, NMO spectrum disorder is frequently disabling from the start, and there are often a cluster of relapses which occur with significant accumulation of disability, and there's good evidence that very early intervention with plasma exchange and corticosteroids can abort attacks and improve and lessen the impact of that attack. So it's something to watch out for in your autoimmune disorders, as it has strong associations with those autoimmune conditions that MV highlighted. Thanks very much.
Thank you very much, Kath, and congratulations to MV for a fantastic presentation. Given the time, we're going to need to move on to the next case. But I'd like to remind all of our presenters, seeing that it's the beginning of a new year, that the real strength of these grand rounds is in the discussion that follows the presentations. And so we like to keep the presentations to about 12 minutes to allow about 8 minutes of discussion with each case. And I ask the consultants to ensure that we are able to keep the time. So I'd like to move to the next presentation, which is from the Division of Medical Gastroenterology. And Dr. Francis will present a case of when diagnostic delay becomes pricing. Over to you, Innocent.
Thanks, Prof. Just want to share my screen. So on presentation mode.
You could either use a slideshow at the top or at the bottom.
Yeah.
So if you scroll down to the bottom of your slide and to the right, yeah, and just click on the one that looks like a presentation next to the slide to the right of your screen. There we go, up to the right of that, next one, and the one to the right of it.
This.
The other right. There we go.
Okay, thank you.
Well done.
All right, thanks so much, Prof. I'll be presenting on behalf of GIT on this important topic, when diagnosis delay becomes pricey, with Dr. Sabelo being my supervising consultant for this case. So here's a 31-year-old female who was referred from the secondary level hospital to us. She's HIV negative and also ex-smoker. She had previous appendectomy done about 15 years ago. Otherwise, there was no other background medical history of note. She had had this abdominal pain with non-bloody diarrhea for more than 1 year and had presented at multiple times to the emergency department, for which she had received several courses of antibiotics and later labeled as IBS case. In January 2021, she did present to the secondary level hospital, and at then the predominant presentation was a low abdominal pain with some tenderness, but no mass was noted on examination. She does have some investigations at then. The stool MCS was blunt with a C. that was also negative as well. In terms of hematological wise, the only remarkable thing that was of note was a CRP of 23 with ASR of 48. Otherwise, the other parameters were within normal limit. She does also have a chest X-ray done and abdominal X-ray that were also unremarkable. The same with an ultrasound and abdomen that was also unremarkable. In March the same 2021, she had worsening symptoms and represented again in April at the same secondary level hospital, upon which she was referred to British Care Hospital as a case of suspected IBD. Now, she came to us and we saw for the first time in April 2021. At then, she had a white cell count of 18.9 with a CRP of over 100.
Recording in progress.
On examination, what was important was that she does have a right iliac fossa tenderness with a mass on that site as well. She went ahead to have a colonoscopy done that showed a destroyed cecum with diseased terminal ileum. And on histology, she does have a chronic active colitis, ileitis. And of note, AFB was negative and there were no granulomas seen as well. Just to point at the MRI, that this is the MRI that she had when she came here. And what is important was the fact that if you look at this site here, this is where the cecum lies. And these are loculations with collections and also with a thickened terminal ileum as well. And just to quickly point out that one thing that could make IBD is IBS. And it's very important that we always look at how they present so that we'll be able to pick out those things that don't really, that will decipher one from the other one. So if you look at IBD, the diarrhea is mostly notional diarrhea, and then also may have also fever with fatigue, and they commonly have hematochezia, and then abdominal cramps, which loss of appetite. Weight loss is very, very important, and they may have anemia, and many a times they may also have some extra intestinal manifestation as well. As against IBS, that commonly their diarrhea mostly it does alternate with constipation. Sometimes they may have predominant diarrhea, and then other times just predominant constipation. Again, their cramps is related to defecation, but there is no weight loss in them, and commonly you don't have other complications like anemia as well. It is said to be linked with stress in most cases among them. Now, if there is this room 4 criteria that you can use to also diagnose IBS, and if you look at it, what is important in that is that if you have recurrent abdominal pain at least 1 day per week in the last 3 months with 2 or more of the following criteria, then you can say this is IBS. So if you have that symptom related to defecation and then associated with a change in stool frequency, or you also have a consistency change as well linked to it, then you can say yes, possibly this is IBS. Of note, we just need to note that these symptoms must have been there for 6 months, but then over the last 3 months, they must be constant. And just to also know that for anyone having chronic diarrhea, there are some few tests that you need to do. These are like baseline tests that one has to take note and do them. You need to have your full blood count and your CRP and ESR. So if you have elevated CRP and ESR, there has to be that antenna being raised that something might be going on possibly. Also, your stool MCS is very important to see if it's inflammatory or non-inflammatory, and then your C. diff and fecal cap protectin. We know that fecal cap pro can sometimes not be very, very specific, but it's going to give you a very, very good guide as well. Then also you need to also exclude things like celiac disease. So you need to do anti-TTG and anti-gliadin antibodies. And of note, iron studies and folate and B12 are very important because it tells you the state of malabsorption and also with terminal ileum issues as well. Then because Crohn's disease can be linked up, it can be a big maker to TB, they can look alike. So chest X-ray is very important, mostly in our setting, so that you must exclude TB as well. Then your abdo X-ray, once you do your abdo X-ray and you're seeing thickening of the mucosa, that should give you a warning sign that something sinister might be happening as well in this patient. Now, back to our own patient. Based on the MRE and the findings from the colonoscopy and also the history, we made an assessment of ileocecal Crohn's disease with a fistulizing phenotype with enteroenteric fistulae as well. There was also the evidence of stricture, and she does have collections with sepsis. And so we need to exclude things like TB and amyloidosis in this lady, which you can do also from your X-ray and then from your biopsy once you do your colonoscopy. Now, just to point out that if you look at the pattern of IBD, this is a typical pattern. So it has this waning and waxing pattern. But if you see, as it goes on, you see that this red line, which represents the mucosal lesions, how destroyed or how affected it is, the longer it is, you see that the mucosa is being destroyed the more. So if you have any diagnosis, then you preserve the gut mucosa, you preserve the gut. But if you have a delayed diagnosis, then by the time you are catching up with the patient, you will have destroyed a lot of the gut. And our patient, at the time they came in, we are already in this sector. We're already having things like strictures and fistula and after. So we have already gone far this way. So a lot of the gut had been affected already prior to presentation in this patient. And just to say that in terms of managing IBD, once a patient presents to you, one of your targets for those who have a moderate to severe disease, your target is to induce remission and then to also maintain them on remission. And so to induce remission, you need either steroid or you need the biologics, which in this case, we do have the anti-TNFs. We have also the anti-integrins, which is like vedolizumab, and you may also have things like the anti-interleukins as well. And so once you induce remission with, depending on what you use to induce remission, if you use a steroid, then you can maintain them with the immunomodulators. So here we have the thiopurine and also have the methotrexate as well. But if you induce remission with any of the biologics, you maintain them on the same biologics as well. Now, in terms of management for our patients, considering the fact that we've stressed the facility because we have a lot of patients already on biologics, and with the high cost of biologics as well, we have to go on a low cost option. So we have to use AZA with prednisone after being on antibiotics for about 1 week. Unfortunately, despite that, she did develop the right iliac fossa collection and required a percutaneous drainage. And because of that, we have to stop the AZA and the steroid. And that now led to a very prolonged admission in the hospital. And very unfortunately for her, she had a long period of time off from her work and unpaid leave as well. And unfortunately still, she was demoted from her work from a higher cadre to a lower cadre because of being absent from work for a very long period of time. She also ended up having elective surgery done as well. She had the resection of the terminal ileum with the cecum. And again, there was a cost implication as well for this patient as well. So if there was that early diagnosis, we would have possibly used a less, more cost-effective modality in the treatment, but now we have to use way more expensive modalities in terms of the treatment. So in summary, for this patient is that we have a 31-year-old lady who had a delayed diagnosis for Crohn's disease, who subsequently presented with complicated IBD with resultant increased socioeconomic burden. Of note is that early diagnosis is less expensive because we can actually manage them as outpatients, and then also there will be cost effectiveness because they're going to use drugs like immunomodulators, which are less effective, and also less investigations as well, as compared to the delayed diagnosis, which will require more expensive imaging like MRI and CT scans, more than one episode as well. So the take-home message for this one is that so in terms of IBD, time is bowel, so when IBD is concerned. So the longer the disease stays, then you are destroying the bowel the more. And indeed, the proverb that says a stitch in time saves 9 is very true in this case. And at this point, I want to hand it back over to you. Thank you so much for the time.
Thank you very much, Dr. Francis. I'd like to invite Sabelo to comment as the consultant on the case.
Yeah, thank you very much.
Sabelo, you're muted.
Sabelo, you're muted.
Can you hear me now?
Yes, we can. Thank you.
Okay. I started by saying just thank you to Innocent for presenting this lovely case, this unfortunate lady. Just to point out that there is enough overlap between the functional conditions and the organic conditions like IBD and celiac disease, to the extent that it's not that uncommon to have the odd case that is wrongly classified because of the overlapping clinical features. It's just the important thing in this particular case, obviously, is that although irritable bowel syndrome or the functional GIT conditions are actually quite common in the population. In fact, if you look at conditions like IBS, it's about 10% of the population. And obviously, if we were to investigate every individual patient with invasive investigations, we wouldn't cope with the caseload. Just to point out that it's quite important to pick up those patients that should be sent for investigation. Just in my plus minus 20 years of experience, I have mislabeled 2 patients that I can remember. And it's often not a bad idea to every IBS patient to give one follow-up appointment just to see that all is good. Because even the early IBD, they can actually have absolutely normal investigation. Unfortunately, the normal stool analysis doesn't give you comfort because with small bowel disease, it's not uncommon for the stool analysis to show no abnormality at all. The fecal calpro, adding the fecal calpro to the normal stool MSNS and clostridium PCR has actually helped to increase the sensitivity of the stool analysis. So in that way, one can actually pick up and obviously adding the inflammatory markers and the other features of malabsorption is quite important in these patients to avoid such misclassification. And just to add as well that the early diagnosis is absolutely important in patients with IBD. Obviously, sometimes it's not the health workers' fault that such patients they come delayed. Some of them, they come requiring an operation already. Okay, but the all the points that Dr. Francis went through, they just help to identify the patients that will need invasive investigation. Thank you.
Thanks very much, Sabelo. So colleagues, I invite you to either raise your hands or type your comments and questions in the chat. And perhaps I can start, Sabelo. So other than the cost differences between biologics and the combination of azathioprine and prednisone, what is the difference in relative efficacy of the two for IBD?
Look, that's a great question. The efficacy of the strength of the biological therapy is the onset of action. I mean, they're absolutely brilliant. The onset is quite quick. And if you look at the studies over the years, there was some concern about sepsis. There's still concern about sepsis. But if you look at the data closely, the steroids are actually the common denominator with the sepsis. So there's no doubt where money is not an issue. Okay, the pendulum really would be, especially the severe cases where you want quicker onset, because the azathioprine, the methotrexate, they really great for maintenance of remission in those that have already are in remission, but for induction of remission, they are not really great. Okay, here in this particular case, we went with steroids with our eyes open. In fact, the timing of her arrival was also unfortunate because we had just pegged our biological list to the PIM. In fact, almost twice what we are actually allowed to actually have, just because of the demand. Obviously, the COVID-19 didn't help because of the delay in our normal monitoring and obviously referral, which contributed. We just have a backlog, so that contributed. But yeah, to come back to your question, there is no doubt the biological therapy, quicker onset, the adverse events profile is much more favorable as well. So I mean, they are really great. And it's unfortunate that the cost, even with biosimilars, is still relatively high.
No, thanks, Sabelo. So I've got a question for Dr. Francis, and I'm delighted that we've got so many of our registrars in attendance at today's meeting. So you've emphasized the importance of early diagnosis, which is clearly unquestionable. But what practical tips can you give to our registrars on how they can ensure early diagnosis of Crohn's disease or ulcerative colitis so that we prevent these pricey complications?
Thank you so much for that. I think one of the very important things we need to consider is a good history. People might come with acute diarrhea, but if you probe them very well, some might have been having a recurrent episode of acute diarrhea and might have been a very long time instead of just that one episode. So taking a very good history is very, very important. And then two, again, once they come, and again from your history, trying to look out for history of weight loss, they are very important. You need to ask for history of IBD in the family. These are very key things that are very, very important. And then your baseline investigations are also very, very key. So if you pick any of those things as being abnormal, your CRP, your full blood count, look out for anemia, and then your stool MCS, if you see any inflammatory stool, it's very, very important. You can do your fecal calc pro. So if you pick anything, and with that, do well to refer as soon as possible. It is better to be on the side of end than just glossing over that. So feel free to refer to us, and then we'll take it up from that point in time. But I think a very good history and baseline investigations is very, very key for our registrar to don't miss out those cases.
Well, thank you very much, and congratulations again for this very instructive case. So I'd like us to move to the final presentation of the day, and that is from the emergency unit, and Dr. Blessings Mkondiza is going to present a case titled Pott's Puffy Tumor. Over to you, Blessings.
Thanks, Prof. Just sharing my screen now. Good afternoon, everyone. So as Prof has mentioned, we'll take you through a presentation of Pott's Puffy tumor, and the consultant for the case is Dr. Derek Evans, one of the EC consultant, medical EC consultants. So I'll start with the case presentation, just a schematic presentation of what a Pott's Puffy tumor looks like. So I have a case of a 15-year-old boy, young man, previously healthy from Guguletu, who came to us in December. Actually was referred with a history of being unwell for the previous 2 weeks prior to the presentation. So just a summary of the symptomatology. Started with upper respiratory tract infection with a cough, some rhinorrhea, and also a little bit of headache. Initially went to a GP where it was treated as the upper respiratory tract infection, and also with a concern of a possible bronchitis. There was some slight improvement in the symptoms after he got that treatment. But then had a sort of recurrence of symptoms, and there was a worsening of headache, developed swelling of the left frontal head, and they're getting quite a lot of fevers. But at this time, of course, there was no alteration in the mental status. There was no seizures, no confusion. And there was a record that was given antibiotics at that point, got flucloxacillin. And the symptoms actually worsened, the headache and then vomiting, and also altered mental status. But there were no seizures that were mentioned. And then was referred to the EC and then the local hospital, and then sent to us. So when the patient arrived in our EC here, was quite unwell. GCS was 10 out of 15. The pupils were dilated 6 millimeters and were sluggishly reacting to light. At this point, I was able to maintain airway, the saturating at 94% on 40% oxygen, was quite pyrexia with temperature of 38.3. The blood pressure was high considering his age, was of 159/90, and heart rate was 86 beats per minute. And there was an obvious fracturant mass on the left forehead that felt like a Duffy, that was kind of Duffy. The rest of the systems examined pretty well. By this point, of course, we booked an urgent CT scan, and the patient, before the patient, and also just to mention that the patient had received a start dose or meningitis dose of ceftriaxone before he was sent to us. And also we did some blood tests as well, and that's the results that we got. The water count was fine, and just the sodium dropped. The sodium was 129, and renal functions were normal, and also had the CRP of 277, which is quite high, and also had CT scan. So just to mention that before the patient went for the CT scan, just dropped the GCS, started vomiting, and the GCS was like 5 at this point, and the patient was intubated went for the CT scan. That's just sharing some images of the CT scan. As you can see, there was some subdural empyema collection there on the left side with some pressure effects. You can see the midline there is shifted to the right. And just appreciate other views as well. You can see the collection there, and up there on top, that's a mass that I was mentioning on the forehead. That's the Port's parfait tumor there. We can still appreciate there that the brain is also quite solid, it's quite edematous. We cannot appreciate the GI and the shift. We can also notice the shift there. We can hardly see the ventricles as well. At that point, the patient was referred to, and that's what's the summary of the CT scan report that we got from radiology. So CTC features with Port's parfait tumor on a background of acute appendicitis complicated by an extensive left subdural empyema, and CT features of meningitis and superior sagittal sinus due to venous thrombosis. And they also mentioned about the cerebral edema and with a raised intracranial pressure and significant right of midline shift and tonsil herniation. At this point, the GCS was about 2T, and we involved the neurosurgeons who came to review the patient. The features were quite concerning, considering that the GCS was also 2T out of 2T, and the patient was not on sedation. So the plan was the surgeon suggested that we. So the plan was just to keep the patient, monitor and see if the GCS would pick up. The plan was that if the GCS picked up, then the patient, they would be taken in for surgery. But they reviewed the patient 1 hour later and remained 2T, and was not for any surgical intervention, and the prognosis was poor. And so that's the patient died, quite a young man. Previously healthy with no comorbidities, which we think if maybe something was done earlier, we could have changed the outcome of the case. So I just want to take you through the Port's parfait tumor, what exactly it is, and just sort of a summary of evaluation, how we approach, and also just treatment. So what is a Port's parfait tumor? So it's basically osteomyelitis of the frontal bone. It's a rare complication of severe frontal sinusitis. It can be acute or chronic sinusitis. It's not common, as Richard mentioned, it's not as common as it used to because of the antibiotics that are given for patients that usually present with sinusitis at a primary health care level. That's not the only cause. The other causes as well, like trauma, can also cause it, and also amphetamine abuse, especially those people that actually sniff amphetamines. They can also, there's some documented cases in literature where they cases that were caused by amphetamine abuse. And also a dental infection can also cause that, and also iatrogenic surgeries that are done to the face, like the frontal cranial surgeries, can also lead to that. So microbiology, as we know that the respiratory tract is colonized with quite a lot of microorganisms, and especially bacteria as well. And most of the times the microorganisms that are involved is the strep, but also oral anaerobes can also get involved, and staph also can get involved. But most of the times it can be polymicrobial, where you have a collection of microorganisms that are involved. And just sort of like a risk factor profile. So this condition is actually common in adolescents, like those they usually present between the age of 6 and 15. The explanation is that the frontal sinus, they usually finish pneumatization at the age of 15 to 18, and pneumatization starts at age 1, and usually there's a lot of pneumatization between age 6 and 15. The explanation is that during pneumatization, there's increased communication between the frontal sinus and the trabecular bone, which eventually also gets with communication with the dural plexus. And that sort of like create an easy communication between the sinus and the cranial cavity. So that's why the presentation usually, the complications usually occur in children that are within this age group, but there are some cases that present earlier than the age of 6. It also can happen in adults, especially that are immunosuppressed for a number of reasons. They can also get it. As I mentioned earlier on, that one of the etiology of rare etiologies of post-perfect tumor is methamphetamine abuse, and especially those that are actually cocaine abusers that are actually snorted, and also head trauma. That's also another risk factor for post-perfect tumor. Because it's usually caused, the predominant cause for post-perfect tumor is sinusitis. I just want to talk about it a little bit of sinusitis, especially the frontal sinusitis. Most of the sinusitis that happens caused by viruses, like acute viral rhinosinusitis, AVRS. And these ones, they tend to be like, the infections tend to be mild. They don't get like severe symptoms, and temperatures are usually not high. And they usually clears within a week or 7 days, but not usually later than 10 days. And these ones, they usually don't complicate to post-perfect tumor. The ones that usually complicate are like acute bacterial sinusitis, which occasionally can superimpose on acute viral. And usually the way one sort of like a rule of thumb and differentiated between AVRS, which is acute viral rhinosinusitis, and ABRS is that, as I mentioned, that the viral usually runs the mild course. They don't have very high temperatures, but ABRS usually they have like very severe symptoms. They can get lots of headaches, and they can get like a rhinorrhea, which is like a purulent discharge from the nasal cavity. They also get quite severe headache, and the temperatures, they tend to be maybe 38 and even 39 and higher than what usually happens with AVRS. And they can also get like the ABRS can give like what is called a double sickening phenomenon, where you have patients that was getting better with a respiratory tract infection, is getting better, and all of a sudden they just like get worse with severe symptoms, high temperatures, and when that happens, usually one has to really consider the possibility of impending post-perfect tumor with a possibility of intracranial extension of the infection. Just a bit of pathogenesis. So usually the spread is hematogenous, especially when it's ABRS is the underlying cause. The pathophysiology is that you get ABRS if it's not partially untreated, treated or untreated, and then it leads to a vascular compromise, and which eventually leads to thrombophlebitis, which eventually can lead to bone erosion and involvement into the durosinuses, and then can spread to the cranial cavity. The direct spread is usually those cases that are caused by trauma, but hematogenous is usually those that are from the infections. A clinical presentation, as mentioned earlier, classically they can present with a forehead mass that's acute and fracturant. It can really resemble other masses, and they can also have systemic signs of infection like fevers, general body pains, headaches, and also the discharge, the nasal discharge can be purulent, and also when there's intracranial involvement, they can get seizures, headaches, and altered mental status as the patient presented. And there are rare clinical presentations that have been mentioned in literature that they can get preceptal cellulitis. There's some patients who can also present with just the frontal cutaneous fistula, as we can see, just a discharge, not really like a mass that actually is coming from the sinus with a bone that has been infected as well. Evaluation, just the usual tear of bloods for blood count and chemistries and blood cultures as well. But usually blood cultures don't carry a good yield. The cultures that are aspirated from the actual mass that have an excellent yield compared to peripheral blood cultures. And of course, imaging to assess for intracranial involvement. CT is quite handy, easy to get, but MRI can also do, but it's expensive and not readily available, especially like in our setting. So just this should be the last slide. The treatment for patients that are quite hemodynamic and stable, usual ABCs, just like our patient was, is quite unstable. Usual ABCs just stabilize the patient, and also because they're quite septic and also they carry very high risk of meningitis, and they do get. Not forgetting that what we usually do in the golden hour sepsis, antibiotics per spectrum, and not forgetting the anaerobic carbon, since the oranodes can also get involved, and of course to de-escalate once we have the sensitivities, and of course source control is also a part of the game. Usually surgical drainage, which can be the open or endoscopic, depending on the severity and the extents of the ports, and also debridement and reconstruction, depending on how much bone has been involved and how much bone has been debrided. That's the end of the presentation. We also have our ENT colleagues that joined the session, because this is like ENT condition, so they can also help with the answering of questions and also the comments contributions. Since this is their bread and butter, they should be able to give us some more input from their experience. Thank you for listening.
Thanks very much, Blessings. Evan, Dr. Evans, Derek.
Thanks very much, Prof. Yeah, I think just for us, we felt that this was actually quite a tragic case. A previously well 15-year-old who became ill and died within a 2-week period. And I think looking at the history, you know, the family presented 2 healthcare professionals on 2 separate occasions. And I think particularly 3 days before he came to C15, he was at the GP with a mass. I don't think it was quite as large, but I think unfortunately it was misdiagnosed. And one has to wonder if he was referred then, you know, would the outcome have been different? And I think it possibly would have. So it really was just one of those cases that struck us. And they are rare. We do not see them often. So we thought it would be one that would be important for everybody to be aware of and identify early, treat, and then refer appropriately.
Thanks, Derek, for those comments. I'd like to invite our colleagues from ENT to see if they would like to make additional comments. I see Darlene.
Thank you. Yes, thank you, Prof. Yeah, thank you. Yes, it is truly tragic. I must say, it's not as uncommon. We see a couple of cases per year, and I must say we haven't had a fatality for a while. But the thing is, once that POTS puffy presents, we take those patients to theatre immediately. You know, they're normally marked as a red. And we would always take it in conjunction with the surgery colleagues, where they would do a burr hole first, and then we would manage the primary source. But what's interesting as well, you know, the literature always says it's osteomyelitis, but it really is only osteomyelitis when you see a fistula coming through the anterior wall. Often the intracranial abscess is not related or not directly behind or posterior to the frontal sinus. And in this case, we didn't see the actual frontal sinus, but it looked like the intracranial collection was quite a distance from the actual sinus. So often we find it's more hematogenous in our setting, and via the diploic veins that this progresses. And once you get this venous sinus thrombosis, it's also very important to start anticoagulating these patients. because that is a poor prognostic sign. But I think the important thing here is, if anybody has an upper respiratory tract infection and they present with any, abscess or collection on the forehead or around the eyes, then those patients need to be scanned urgently. So I think if he was referred earlier, it seems like the holdup was from the day hospitals and from the GP. So I do think it's really important to recognize this.
And Darlene, I wonder if
there's
you can
any
comment on the common organisms that are causative.
So it's the same as for acute sinusitis. So it's often your staphylococcus, your streptococcus, and your moraxella. So those are the three important ones. So we would treat it the same as neurosurgeons would treat acute bacterial meningitis. So a high dose ceftriaxone with cloxacillin, and often they would add an anaerobic kind of flagell cover. But normally the ceftriaxone and the clox should treat this. So if you have a frontal sinusitis, it's usually, in this case, the one image showed the maxillary sinus, which was pacified. But what is important to note, especially in adult, if you see an isolated sphenoiditis, those are the ones that you have to be super, super careful of, even more so than the frontal sinusitis, because they present with your cavernous sinus thrombosis very, very quickly. And that's usually a staphylococcus if you see an isolated sphenoid sinusitis. And that for us is also a sign to go in immediately if a patient has headaches with high fever and a sphenoid opacification. We had one patient that died in our ward a couple of years ago from a sphenoiditis with multiple septic emboli to the brain.
Mm-hmm. Eric, I was going to ask what your thoughts were on the renal dysfunction. Do you think that was just all part of the sepsis, or was there another underlying cause?
I'm sorry, Prof. Can you just repeat that on comment?
No, I was asking about the quite significant renal dysfunction. If you thought it was all driven by sepsis, or whether there was another cause.
Yeah, we did suspect that he was quite septic. Again, it was interesting that his white cell count was 7, with that significant sepsis on board. One also has to think about the level of consciousness, and was the child actually feeding, and for how long? What did he have a reduced level of consciousness? I don't know if that also could have potentially contributed. I think that probably was the case. We went on to single patient viewer because I wanted to give feedback to the day hospitals. And unfortunately, it looks like he went to the GP on both occasions, and I was unable to track the GP down. Just to give them feedback, because it is. I thought that would be really important. So I was unable to track the GP down, but I would suspect it was a combination of sepsis and the reduced level of consciousness. Probably for a couple of days, he probably wasn't feeding.
Maybe as a final word, I can ask Darlene to regale us with the curious name of this condition and the story of the history, if you know it.
Actually, Potts Puffy. I actually have to look that up. I think that was named after someone specific. Mr. Pot. I don't know. I'll have to look that up and get back to you.
Pot, the father of orthopedics, who also described TB of the spine.
Exactly. Yes.
There's a funny story around it.
But I see Ian Ross asked a question here about the danger triangle of the face and whether it's an important clue to possible intracranial infection. And that's something we see very often, but not in relation to a Potts-Puffy tumor. So if someone has a vestibulitis, or the danger triangle is anything, from the dorsum of the nose. So it's often the people with a vestibulitis, so a small pimple in the nose that they then try and expel. And because there's no valves, it's in the facial veins, it's a valveless system. There's direct spread via the ophthalmic veins and via the pterygoid plexus veins to the cavernous sinus. So those patients present with a cavernous sinus thrombosis, so ophthalmoplegia, so unable to move the eye, and proptosis. When you do the scan, essentially the scan of the sinuses will be normal. So that's a definite sign of, and the danger there is that it moves to the other side by the intercavernous sinus.
Well, thank you very much. A really fascinating case and great set of presentations. Congratulations to all of our speakers. And thanks to all of you for attending in such numbers. I wish you a lovely day. Bye.